السلام عليكم ورحمة الله وبركاته. معكم دكتور محمد حسن ضفاء الله، اختصاص الباطنية والغدد الصماء. حنتناول إن شاء الله الليلة كيس جديد. هذه المادة التعليمية صدقة جارية للمغفور لها بإذن الله دكتور إسراء محمد سليمان، خريجة الدفعة السادسة. طيب, the chief complaint is shortness of breath. So, history of presenting illness. This patient is a 41-year-old woman, gravida 4, para 4, who recently delivered a healthy boy via spontaneous vaginal delivery and presents to the emergency room with complaints of progressive shortness of breath for the past 2 days. She says that in the last days of her pregnancy, she would feel slightly short of breath when walking fast, which is normal for her pregnancy. 3 days after being discharged, she experienced the above symptoms. She says that even walking to the bathroom now, which is a few steps away from her room, has become very difficult. The dyspnea, or the shortness of breath, improves with rest. She denies chest pain, palpitations, and lightheadedness, but she admits to an occasional cough when she lays down at night, with expectoration of small amounts of clear sputum without blood. She denies any sick contacts. So this is a 41-year-old woman who just delivered a baby boy, and she has complaints of shortness of breath with minimal exertion. On review of systems, she denies fever, night sweats, but she does report easy fatigue over the past week. No headache, no limb weakness, numbness, neck pain, skin or hair changes, other than the pregnancy-associated hyperpigmentation in the face and abdominal striae. She denies abdominal pain, but she reports early satiety, and she feels full very quickly after she eats. She admits to bilateral lower limb swelling, which has increased since delivery. The past medical history is positive for controlled hypertension during pregnancy, but she is otherwise healthy. She says she is up to date with all her vaccinations. Family history, she is unsure about similar conditions in her family. Social history, she is a stay-at-home mother of 4 boys, including the just newborn. Her husband uses tumbak, but he does not smoke cigarettes. Medications and allergies, she did not use antihypertensive medications during pregnancy, which is common. We don't always give pregnant women with hypertension antihypertensives. There is a limit to when we start treating hypertension during pregnancy. She also denies any known allergies. On physical examination, her vital signs, her blood pressure is 110 over 60 millimeter mercury, heart rate is 91 beats per minute, respiratory rate is 25 per minute, temperature is 37.6 Celsius, and her oxygen saturation is 94%. On general examination, she appears dyspneic and avoids laying flat in the table. Head, ears, eyes, nose, and throat. There is no pallor or periorbital edema. She has a jugular venous pressure of 13 centimeters of water, and there's no carotid bruit. So she only has jugular venous distension. Cardiovascular exam. Apex is at the 5th intercostal space, but it is laterally displaced from the midclavicular line. She has a normal S1 and S2. There's no added sounds or murmurs that were noted. On chest examination, there's equal chest expansion. There's no dullness to percussion, but there's bilateral basal crackles. No egophony or vocal resonance was audible. Abdominal examination, the abdomen is slightly distended, which is consistent with the postpartum state. Her liver edge is felt 3 centimeters below the costal margin. There is no splenomegaly or ascites noted. Her extremities showed a 2+ pitting edema, noted in both lower extremities. She has normal equal pulses bilaterally. So we have a question. What laboratory or imaging investigations should be done for this patient? الناس توقف الفيديو تفكر في الإجابة وبعد ذاك تواصل. Okay, so we want to know what laboratory or imaging investigations should be done to come up with the diagnosis. Again, pause the video and think about the answer before proceeding forward. Okay, so these are the investigations and imaging that was done for the patient. Her hemoglobin is 10 grams per deciliter. Sodium is 132. Potassium is 3.7. Bicarbonate is 21. BUN is 10. Creatinine is 0.9. Her D-dimer is 0.1. Her pro-BNP or pro-brain natriuretic peptide is 15,040 nanograms per liter. Her troponin T is 7. And a lipid panel was done, which was all normal. Her ECG shows a normal sinus rhythm, and there are voltage criteria for left ventricular hypertrophy. An echocardiogram was done, and it showed dilated cardiomyopathy, or findings consistent with the dilated cardiomyopathy. Her ejection fraction was 38%, with some regional wall motion abnormalities. There was trace mitral regurgitation. There's no intracardiac thrombi were seen. And this was the chest x-ray that was done. Take a few moments to think about the findings that are in the chest x-ray. So when we look at the chest x-ray, we look at the bones and see if there's any irregularities or any interruptions in the bones. So here you see both of the clavicles. Here you see the ribs posteriorly, because this is a PA image, posterior anterior image. So you can see the shadow of the first rib here. This is the second rib, third, fourth, fifth, sixth, seventh, eighth, probably the 9th, 10th, 11th, and maybe this is the 12th rib. So then you will also look at the shadow of the trachea and the main stem bronchi, which should appear. Okay, and then there's the heart shadow also. Okay, and then you look at the soft tissue to see if there's any evidence of any subcutaneous emphysema or anything like that. And you look at the lung fields also to see if there's any discontinuity of the vascular markings to suggest pneumothorax, or if there is vascular congestion, such as what we see here. And you also look for any evidence of local consolidation. If there is any here, we don't see any local consolidations. You also look at the costophrenic angles to see if there's any blunting of the costophrenic angles, which may suggest pleural effusion. So this is just a very quick overview. I didn't talk in detail about how to read a chest x-ray, but what we find here is that this patient has cardiomegaly, and she has prominent vascular markings consistent with pulmonary edema. There's no pleural effusion in this patient. Otherwise, I don't see anything that is significant in this chest x-ray that we need to mention. Now, let's look back in the lab investigations. I didn't include the normal values, but her hemoglobin is normal. She's just recently delivered. She has probably a dilutional anemia, so this isn't very significant here. Her sodium is also normal. Potassium is slightly low, but that's not very much a big issue. Her bicarbonate is slightly low. She probably has a little bit of respiratory alkalosis, and she is trying to compensate with some reduced bicarbonate. Her BUN is normal, creatinine is normal. D-dimer is done usually according to the laboratory value. They should normally give you a normal laboratory value, but here it is normal for the sake of this case. Her pro-BNP, however, is elevated remarkably. Normally, it is less than 300 or 400 maximum, but here it is 15,000. So this is markedly elevated pro-BNP, and it suggests that there is stretching of the ventricular walls of the heart and this brain natriuretic peptide is released. Her troponin is also elevated. This is probably because her heart is doing a lot of work with limited supply that it gets, so her troponin is elevated. But this is not something that is concerning if there is no evidence of coronary atherosclerosis. And so this is a young patient, she's a female, she doesn't have any lipid abnormalities, doesn't smoke, she's not obese, according to, at least from the chest x-ray that we see, and it wasn't noted on her examination that she was markedly obese. So we wouldn't think about much of an issue with coronary occlusion. Also, her ECG didn't show any changes consistent with ischemia. However, if there is any issues, it would be due to demand ischemia rather than a supply ischemia. And her echocardiogram, as we noted, shows dilated cardiomyopathy. So the question is, what is the most likely diagnosis? Now, take a few minutes to think about the answer and then proceed forward. إذا يحتاج الأمر ممكن ترجع لل laboratory values, and you can go back, read the case again, think about what the most likely diagnosis is before proceeding forward for a better learning experience. Okay, so the most likely diagnosis is peripartum cardiomyopathy. Now, it is a diagnosis of exclusion, so you have to exclude other things first. The definition of peripartum cardiomyopathy is that it is an idiopathic cardiomyopathy presenting with heart failure secondary to left ventricular systolic dysfunction towards the end of pregnancy or in the months following delivery, where no other cause of heart failure is found. Now, there are some other definitions that limit the postpartum state or postpartum duration to 5 months. However, newer definitions have emerged, and they say that they made it more generalized. So they said in the months following delivery. So they didn't limit it to 5 months. It can be extended to a little bit longer. Usually the left ventricular ejection fraction in these patients is less than 45%, and there may or may not be ventricular dilation. So the hallmark usually is heart failure features with a reduced ejection fraction, but otherwise you have to exclude other diagnoses. Now, how common is this problem? It's not very common. It's the incidence varies from 1 in 1,000 to 1 in 4,000, and some other papers it's 1 in 3,000, but it is not very common. However, it is something that has a high morbidity, mortality, and it affects the quality of life of women who have just delivered newborns. And so it's not only the mother that is affected, but also the newborn that is affected by the mother's cardiomyopathy if it occurs. What are the risk factors? When do you suspect these patients to get cardiomyopathy? African ancestry, يعني عندنا نحن في السودان our patients are of African ancestry, and so even in the United States and in UK, patients who are of African ancestry seem to have more risk of peripartum cardiomyopathy. Preeclampsia and hypertension, such as in our patient, is another risk factor. Those who have multi-fetal pregnancies or multiple gestations, so if she had delivered twins or triplets, etc., these are more risk of getting peripartum cardiomyopathy. And older maternal age. So our patient was 41 years old. She had a little bit of an advanced maternal age, and so this is another risk factor. So our patient had three risk factors. So older maternal age, preeclampsia, and hypertension. And we assume that this is a patient in Sudan, so it is she's of African ancestry. So what is the pathophysiology of this disorder? The etiology is poorly understood. There are several thoughts out there about why it happens. There are some studies that suggest that it is a vascular disease, and it's triggered by peripartum hormonal changes. And prolactin was implicated here. Its breakdown products have some sort of a vasculotoxic effects, and some other hormones that are affected by these breakdown products also have a vasculotoxic effect. But these are all theories. It's not proven 100%. It was theories based on animal models. So human models have yet to prove whether this is in fact true or not. And there are some experimentation with dopamine agonists to lower the prolactin in these patients who have peripartum cardiomyopathy to see if it causes any improvement. But like I said, these are still experimental, and we've yet to see data that proves this theory in humans. There are some other genetic studies that have identified pathogenic variants in genes of afflicted patients, supporting a two-hit hypothesis, meaning that some patients are already predisposed genetically, and then there is another environmental effect that comes into play, which might lead to the peripartum cardiomyopathy. So genetic risk factors have also been identified. But of course, it's still not well understood, the pathophysiology. Now, the problem is that diagnosis is often delayed because the symptoms overlap with normal pregnancy. يعني بتيجي المرأة الحامل بتكون عندها shortness of breath, عندها lower extremity swelling, and we think this is just normal pregnancy, and we fail to make the diagnosis because this assumption. And so the important thing to note is that you have to look at the risk factors. You have to ask the patient whether these are newer or worsening symptoms, and how are they affecting the patient's quality of life. And making the diagnosis is not very difficult, but you have to have the differential in your mind that this might not just be normal pregnancy symptoms. You need echocardiography for diagnosis, and you have to rule out intracardiac thrombi, especially when the ejection fraction is severely reduced. So if it's less than 30% or 25%, you have to look for intracardiac thrombi, because this can put the patient at high risk for thromboembolism, which would lead to a embolic stroke. فتخيل تكون وحدة يا دوب ولدت عندها طفل عايزة ترضعه تيجي بسيمتومز بتاعت heart failure she ends up getting a stroke. So it's very, very devastating, very poor outcome. So you wouldn't want that to happen. You have to rule out intracardiac thrombi. If the echocardiography report does not mention if there is intracardiac thrombi or there is not, you have to go back to the technician or the cardiologist, whomever does this echocardiogram, and you have to ask them to look into the chambers, especially the left ventricle, to see if there are any thrombi, because you wouldn't want to lose this patient to a stroke just because a thrombi was missed. So this is very important to note, especially if the ejection fraction is reduced. If the ejection fraction is, let's say, 44 or 43, and it wasn't mentioned, you can probably get away with not specifically looking to see if there's any intracardiac thrombi. However, it is worth the while. So another question, how should peripartum cardiomyopathy be managed? So take a few minutes, think about the answer before proceeding forward. Okay, so peripartum cardiomyopathy is the most common cause of cardiogenic shock during or shortly after pregnancy. Again, note, this is cardiogenic shock, not just general shock. Normally, if the blood pressure is very high, we sometimes use nitroprusside. However, here there is a risk of cyanide toxicity from this nitroprusside. So you should avoid nitroprusside. And the outcomes may be worse with dobutamine, according to some studies. So this is something that can also be avoided. So avoid nitroprusside and dobutamine. If the patient gets peripartum cardiomyopathy while she's still pregnant, you might need to perform an early delivery or termination of pregnancy if the patient is hemodynamically unstable. If she is hemodynamically unstable, just closer monitoring until the pregnancy naturally ends with delivery. However, if the patient starts to become hemodynamically unstable, strongly consider ending the pregnancy, okay? Because the life of the patient is much more important than completing the delivery. And nowadays, with the advancements in neonatal ICU care, we can do this in a bit of a safer manner. So stable patients can be or can deliver vaginally unless there is an obstetric reason for a cesarean section. فما كل البيشنتس بيحتاجوا cesarean section. Postpartum risk of decompensation should also be anticipated. فما عشان البيشنت عملت normal delivery and she is not hemodynamically unstable that things can't get worse. They can. فخلي بالك من العيانين ديل and don't assume that they will get better after they deliver. So this isn't like preeclampsia, for example. This can actually start to happen after delivery. فنحن الكيس بتاعتنا البيشنت جات بالسيمتومز بعد ما ولدت. So during subsequent pregnancies, women with peripartum cardiomyopathy should be closely followed with serial clinical assessment, echocardiogram, and BNP, or brain natriuretic peptide, from prior to conception until after delivery. العيانة إذا جات peripartum cardiomyopathy أي pregnancy بعدها لازم نتابعها very closely عشان لأن عندها higher risk of getting peripartum cardiomyopathy. Normally during pregnancy, you should avoid ACE inhibitors, ARBs, and aldosterone antagonists because they cause renal damage in the fetus. They should be discontinued prior to conception. So patients ديل بدوهم ال ACE inhibitors, بدوهم ال ARBs, بدوهم aldosterone antagonists. يعني ما كلهم مع بعض طبعا لكن they get these medications, and if the patient wants to conceive, she wants to have a baby, you have to discontinue these medications prior to the patient becoming pregnant. يعني ما بعد ما نكتشف إنه patient pregnant حتى نقول لها وقفيهم. No, you have to stop them prior to the patient becoming pregnant. Communication with the patient is very, very critical to know what their plans are. يعني مرات في patients يقول لك أنا بالنسبة لي إنه أنا أكون يعني أحمل والولادة is very important to me, so I don't want to not become pregnant because of this problem. So you have to communicate with the patients very clearly about what their wishes are and what they want to do. So this is a nice table or diagram here that I found, and just to go over peripartum cardiomyopathy quickly. So we talked about the definition is that it's a non-ischemic cardiomyopathy, usually presents in the first months postpartum towards the end of the pregnancy. Okay, so the risk factors we also mentioned: advanced age, African race or African American race, preeclampsia, hypertension, if she has multi-gestation or multiple pregnancies. Symptoms are similar to those of heart failure, but they can be confused with those of normal pregnancy, as we've mentioned. And so the management, if it's during pregnancy, these patients get beta blockers, they get diuretics, they get hydralazine with isosorbide dinitrate if they have severely, or if they have a low ejection fraction that is quite severe. They can also get digoxin, and they get anticoagulation with low molecular weight heparin. You should not use ACE inhibitors, ARBs, or aldosterone antagonists. These patients might need mechanical circulatory support if they have severe heart failure or cardiogenic shock. So they might need to be placed on some sort of a machine, or they get inotropes, you should consider early delivery if the patient is hemodynamically unstable. In terms of the delivery, you have to plan ahead with the obstetrical team. If the patient is unstable, you monitor hemodynamics, and you caution for fluid overload, especially after delivery. But patients ديل يفترض نهائي ما يدوهم extra fluids during delivery. And you have to consider that if you need to give blood transfusion, you have to have a strong indication to do so. ما بس أي patient يدوها blood عشان هي قاعدة تولد and she had lost some blood. You have to have very strong indications for that. After pregnancy, you manage the heart failure as you would with any other patients. You can use ACE inhibitors. You can use aldosterone receptor antagonists such as spironolactone, and you can use these during the breastfeeding. There's no issues with that. Anticoagulation. If there is a left ventricular thrombus, you give them therapeutic anticoagulation, yani higher dose of anticoagulation, especially if the ejection fraction is lower than 35%. And consider giving the patient a cardioverter or defibrillator, بدون wearable cardioverter, if there is severe LV dysfunction. لأن العيانين دول عندهم high risk of getting arrhythmias. فالديفيبريليتر اللي بيلبسوها دي قد تستنقذ حياتهم. يعني الواحدة ممكن فجأة تجيها arrhythmia، فالديفيبريليتر دي it detects the arrhythmia and it gives a shock if the patient if the arrhythmia is a shockable rhythm. Okay, you have to discuss contraception with these patients لأنه الريسك بتاعهم very high، فلازم تتكلم عن contraception at least until the heart failure goes away and they are able to monitor very closely with a cardiologist during the subsequent pregnancies. But a discussion about contraception is key, very important. Okay, these are just a note here that warfarin is contraindicated during pregnancy، فعشان كده بنديهم low molecular weight heparin. But لكن الهيبرين and the warfarin they're okay during lactation. فحتى إذا عندها left ventricular thrombus وداير تديها warfarin after delivery, it's okay. So the outcomes, most patients have bad prognosis if they have a low ejection fraction, if there is a dilated left ventricle. Patients who are of African ancestry أصلا هم predisposed لكن الoutcomes بتاعهم كمان أسوأ. And if you have a delayed diagnosis. عشان كده be very careful. جات مرأة وبتشتكي من shortness of breath, take it seriously. لأنه معظم النسوان الحوامل بيحسوا ب shortness of breath. لما يجي يشتكوا بها معناه there's an issue. Take it very seriously and keep this diagnosis in the back of your mind. Okay, so long-term outcomes after recovery, optimal duration of medication treatment is unknown. ما في studies كفاية بتورينا إنه how long we should continue these patients on heart failure medications. If you are stopping medications, you have to do it gradually and you have to observe closely. لأنه مرات في patients إذا فجأة وقفت الأدوية they might decompensate فجأة. So you have to wean them gradually بالراحة to start to lower the doses and take one medication one by one. And then you have to continue surveillance after recovery لأنه مرات they can decompensate again or they can go into heart failure again. So this is the main article that I got most of this information from. It was just published in 2020 in the Journal of the American College of Cardiology. So I hope this was useful. Please keep this diagnosis in the back of your mind. It's not as rare as we think that it is. I've seen a couple of cases. Keep this in the back of your mind. It will save a lot of lives. And thank you for tuning in.